Hello, I am Jolie Long with the National Board for Certified Counselors. On behalf of the Medicare Mental Health Workforce Coalition, we would like to welcome you to our webinar today. Next. Before we begin, I would like to share some meeting details. Closed captions are now enabled and attendees can turn these on and off as desired. Interpreters can join the meeting via the phone number, ID, and passcode provided on this slide. A link to the PowerPoint presentation will be posted in the chat, so you can access the links on this slide. To receive continuing education credit, you must complete the session evaluation. It will be posted in the chat at the conclusion of the webinar. We will only be providing credit for live attendance. This webinar will be recorded and made available on the NBCC website and other coalition member websites for viewing purposes only. Due to the large number of attendees, the participants will remain in listen-only mode throughout the meeting. During this presentation, the presenters will be answering questions that were previously submitted via survey. You may submit questions into the Q&A box at any time, and we will use these to inform future webinar topics. Next. The Medicare Mental Health Workforce Coalition consists of organizations that collectively represent providers, clients, patients, and other stakeholders. Our overall mission is to increase access to client choice for mental health provider care. Together, we achieve this goal with the passage of the Mental Health Access Improvement Act. The coalition is now working to ensure successful integration of counselors and marriage and family therapists into the Medicare program. The coalition members are listed on this slide. Next. Today, you will hear from a panel of experts to help you understand the proposed rule for the 2024 Medicare Physician Fee Schedule. The panelists will answer your questions about the rule and the addition of counselors and MFTs into Medicare. The speakers will touch on all of the learning objectives listed here. I would now like to welcome Dr. Beverly Smith, Interim Executive Director and CEO of the American Mental Health Counselors Association, to provide opening remarks and to introduce our speakers.
Thank you, Ms. Jolie Long. As stated, I'm Dr. Beverly Smith. So good afternoon to each of you. On behalf of the American Mental Health Counselors Association, also known as AMCA, and the Medicare Mental Health Workforce Coalition, I would like to welcome you to part 4 of this webinar series, focused on the 2024 Medicare Physician Fee Schedule rule and implications for licensed counselors and licensed marriage and family therapists as they prepare to participate in the Medicare program. The intention of the series is to educate, prepare, and keep you informed of the steps to integrate our practitioners into the Medicare program in the most effective and efficient way possible. The coalition partners continue to work closely with the Centers for Medicare and Medicaid Services to ensure that you have ongoing information to support you during this process. Later in the program, several CMS representatives will join us to share more information, answer your questions regarding the Medicare program. AMCA is a proud member of the Medicare Mental Health Workforce Coalition. We are a proud member, and we'll proudly advocate for over 130 licensed mental health counselors in the nation. We are indeed the only organization that exclusively advocate for licensed mental health counselors, licensed professional counselors. We know the inclusion of licensed counselors and licensed marriage and family therapists will have a significant and lasting impact on the mental health of Medicare recipients as well as their families. If you attended the previous webinars, welcome back. If this is your first time with us, we welcome you here today. This is a unifying time in our profession, and we look forward to easing the workforce shortage across the nation and increasing access to quality mental health care for all populations. Now, I'd like to introduce you our speakers for today. On the next slide, as you see, we have Jenny L. Vance, JD. Jenny is a healthcare transactions and regulatory attorney who is a partner with the Sacramento-based law firm of Weintraub Tobin. Jenny has expertise in Medicare and Medicaid payments and enrollment matters, healthcare operations, and healthcare mergers. Jenny advises healthcare professional groups and associations regarding healthcare licensing and payment requirement for compliant business structures. She's currently the chair of the Regulation, Accreditation, and Payment Practice Group of the American Health Law Association and was previously the president of the Sacramento and Health Law Committee and a vice chair of the California State Bar Health Law Committee. Jenny received her law degree from the University of California Law, San Francisco, and her undergrad degree from Mills College. Our next speaker for today is Dr. Doug Jacobs. He's the Chief Transformation Officer in the Center for Medicare at the Centers for Medicare of Medicaid Services. In his role, he helps to lead center-wide efforts to move the healthcare system towards value-based care, advances health equity, and promote delivery system transformation. Prior to this role, he was the Chief Medical Officer for the Pennsylvania Department of Human Services, where he helped oversee the state's Medicaid program. And our third speaker for today, Ms. Long. Ms. Long is the Legislative Research Partner in the Government and Legislative Affairs Department for NBCC. She works to develop and implement state and federal policy initiatives to promote professional excellence and strengthen the regulatory framework of the profession. She also expands governmental recognition of counselors and increase access to high-quality counseling services. Long analyzes active legislation and policy and coordinates advocacy, lobbying, and grassroots efforts on behalf of counselors and the profession. I would now like to invite Ms. Jenny Vance to begin her presentation.
Thank you so much, Dr. Smith. I appreciate the Coalition's invitation to participate with you all. And I'm really excited that we have representatives from the Centers for Medicare Medicaid Services here to provide some additional information on Medicare payment for MFTs and MHCs. That's a really exciting opportunity. And I've been peeking at some of your questions that have been percolating up in the chat. And I'm pleased to note that at least some of them will be answered in this presentation. Next slide, please. So the Medicare Physician Fee Schedule was proposed by the Centers for Medicare and Medicaid Services. This is a part of our governmental procedure on how to enact regulations in the United States. Is they get published as a proposal in the Federal Register. People have the opportunity to make comments on them, and then if the constituents write back to CMS and make various comments, then CMS is required to engage with those, and then they'll let us know in the final rule that comes out. They'll actually say, yes, we considered this, and sometimes they'll make an adjustment, and sometimes they'll tell you why they didn't think it was appropriate. So that's where we are right now. We have the proposal. It was published on August 7th, 2023. Anyone can look at it. You go find this copy of the Federal Register, which is available online. And it's very lengthy. However, the part that deals with us is not so long. So there's a index, and there's a table of contents at the beginning that'll help you sort of traverse to find, the parts that we're going to talk about here today. Anyone that would like to make a comment, the comments are due to CMS on September 11th, 2023, and it tells you in the proposed rule how to make those comments. And then the final Medicare Physician Fee Schedule with the final regulations, after taking into account the various comments, typically gets published right around November 1st or so, and it will be effective January 1st, 2024. Next slide, please. Medicare payment is to begin for services delivered by MFTs and MHCs for services starting January 1st, 2024, if folks get enrolled in the Medicare program. In order to become enrolled and be paid, marriage and family therapists and MHCs must have a master's or doctoral degree and meet the qualifications for state licensure. You must actually be licensed and then have performed some post-degree clinical supervised training of either 2 years or 3,000 hours. It was a nice surprise because I know the statute on its terms said you have to have 2 years, but you could get an equivalent of 3,000 hours set forth in the regulations. MFTs and MHCs can only be paid for services that are delivered to outpatients. And the services that practitioners will be paid for are only those services that would be paid to a physician if the physician had delivered those same services. It does include, and this was a little bit of a surprise to me personally, payment for addiction counselors if addiction counselors meet those requirements, which is, master's degree, doctoral degree, and all those hours of post-degree clinical experience. I've given you the citation in case you'd like to find it yourself in the Federal Register. Next slide, please. I'm going to give a little bit of background on the Medicare Physician Fee Schedule because that'll help us to understand some of the comments in the proposal. Next slide, please. The rate of payment for MFTs and MHCs is the lesser of 80% of the practitioner's actual charge or 75% of the amount paid to clinical psychologists under the Medicare Physician Fee Schedule. On the next slide, I have put out an example of how this works in practice. So I just picked a pretty common CPT code that might be provided and billed for, and that is a 50-minute psychotherapy session, code number 90834. If the practitioner has a usual and customary charge that they would charge to their patients who were private pay of $195 for this service, I went and looked up, CMS has a really nice lookup tool on its website called the Physician Fee Schedule Lookup Tool. And the link to that is in the materials for the Medicare 301 webinar, if you attended that. And so I put this code in Northern California, which is where I live. The Medicare rate for a clinical psychologist would be $114. So Medicare would pay an MFT or an MHC 75% of the $114 because the $114 was lower than the actual charge of $195. So that amount would be $85.50. A portion of that is the patient copay, which the practitioner needs to collect from the patient, and then whatever's left would get paid by Medicare. Next slide, please. All right, this is the way that Medicare rates get calculated. So if you want to understand how we came up with $114, this is it. And we have a lot of acronyms on this page, and the next couple slides will tell you what each one of these means. So the payment amount is the sum of the work RVU time or relative value unit times the work GPCI or the geographic practice cost index added to the practice expense RVU multiplied by the practice expense GPCI and the added to the malpractice RVU and the malpractice GPCI all of that, the sum of those three things is multiplied by a conversion factor, which is a dollar amount that gets applied as a factor in every single service that gets paid for under the physician fee schedule. Next slide, please. The relative value units, the RVUs, we have the three types here. And these are all listed in the Medicare Physician Fee Schedule, and they're columns by code that you can look up what these are if you're interested. And it has a column for work RVUs, and that's a value that values the relative time and intensity of a given service. How difficult is it? How time consuming it is. Practice expense shows the costs of performing that practice. So things like office rent, subordinate staff costs, et cetera. And then finally, the malpractice expense is accounted for in the malpractice RVU value. Next slide, please. Each of those factors is adjusted for a geographic differences in the cost of delivering care, and that's known as a gypsy. And then, as I mentioned, that conversion factor is where the dollars get multiplied by all of those factors to come up with the rate for each CPT code. Next slide, please. To be reimbursable under Medicare, each of the following must be permitted under the Social Security Act for the Medicare service to be paid. The specific service must be reimbursable. The method of delivery must be reimbursable, and then the person must have been approved to be a Medicare provider, and that is by going through the enrollment process. Next slide, please. So now with that background, I'm going to go into some of the specific proposals other than the obvious one of MFTs and MHCs are going to be paid. So there are a variety of other components that were proposed in the physician fee schedule. Next slide, please. The first one is that ancillary services that will enhance professional services that are ordered by MFTs and MHCs will also be paid. So MFTs and MHCs can order diagnostic tests when those tests relate to the professional services that are being provided. And then assuming that those tests are Medicare approved, then Medicare would make payment for those tests as well. Next slide. This is a new service that MFTs and MHCs would be reimbursed for, and that is the health behavior assessments and intervention services and behavioral health integration. HBAI is a psychological assessment and treatment when the primary diagnosis is a medical condition. So, it's a sort of an enhancement to, physician services. That service may be provided to individuals or groups. It's when a psychological condition might be contributing to a physical health condition. In addition, certain BHI services have been reweighted from what they have been paid up to now to increase reimbursement for 2024. And that's something that happens each year under the physician fee schedule. There are relative weights of all of the different kinds of healthcare services that get paid for under the system. And CMS each year will go through and reweight certain things as either, greater realization, technology changes, or frankly, policy changes that CMS or, legislation indicates should be more highly valued. So at one point there was a lot more focus on primary care services, et cetera. Now we certainly are in the midst of, greater federal support for, expanding access to behavioral health services. And so that's what you see here. Next slide, please. Another setting in which MFTs and MHCs might provide services is the rural health clinic or the federally qualified health center. So these practitioners were added to the eligible staff for both of those provider types. The conditions of coverage have been updated, and that's the conditions of coverage for Medicare services. If MFT or MHC is providing services in one of these settings, it's paid for a little bit differently than just the practitioner billing under the Medicare Physician Fee Schedule. So what happens is in an FQHC, those services get paid to the clinic as part of a prospective payment system. So so the clinic would be billing along with all of their other services based on whatever the diagnosis is of the patient. And then in an rural health clinic, it's a similar alternate method of payment for those services. And those services would get paid in an all-inclusive rate. Again, services not billed directly by the MFT and MHC. So there, the practitioner would be compensated by those clinics. Those are both considered safety net providers. Same policies and supervision requirements in those settings would be provided to MFTs and MHCs as currently exist for social workers and psychologists. And then there are the same basic eligibility requirements as for Part B suppliers. Next slide, please. Hospital interdisciplinary groups, hospice interdisciplinary groups may include MFTs and MHCs. So hospices currently are required to have interdisciplinary groups, which would include a social worker, but the groups will be expanded so that those needs for a social worker could be also comprised of a marriage and family therapist or a mental health counselor, depending on the needs and preferences of the patient. So again, a new setting that MFTs and MHCs could be providing services in with Medicare payment. Next slide, please. Telehealth services may also be provided by MFTs and MHCs under the proposed rule. Medicare will cover those telebehavioral health services through December 31st, 2024. There's been a great deal of change in the payment of telehealth services by MFTs and by providers in general since the onset of the pandemic. And so the requirements for Medicare payment for telehealth services was somewhat restricted. And then there was a great expansion of the circumstances under which those services could be provided, of course, during the pandemic. That some of those waivers and those flexibilities have expired when the public health emergency ended, but some of them have not. And here you have something that is still categorized as a temporary extension. But, you know, I assume that this group would want to advocate for that to continue long, and we have their folks beyond the December 31st, 2024. And so we have folks from CMS here who, you know, I'm certain can be hearing that. In addition, mobile crisis codes, there was some discussion about what would be the location where those services could be provided to be paid for by under Medicare. And the proposal from CMS is that those crisis codes could be billed for services delivered in any location, even if it was, you know, telehealth. Next slide, please. Provider enrollment for MFTs and MHCs. So if you want to get paid by Medicare directly, you need to enroll in the Medicare program. And you can submit an application in one of two ways. First, you could complete a paper application. It's the 855I form, which is available at the link that's listed below. And then you send that to the Medicare administrative contractor, or you can complete that same application electronically using the PACOS portal, and there's the website where you can find that below. If you participate in a group, if it's not just going to be you individually, then that group needs to also complete the 855B, and then you would complete the 855R to link yourself to that group to be able to reassign whatever benefits you have coming from the Medicare program to that group. Next slide, please. Under the proposed physician fee schedule, there are 3 screening levels that a provider would go through. You apply, and then CMS and the Medicare Administrative Contractor will do some sort of background check on you and verify that the information is accurate and complete. And there are 3 default screening levels. One is limited, one is moderate, and one is high. And so the default screening level for practitioners applying is the limited risk screening level. And what that means is there's not an automatic site visit or fingerprint-based background check. However, practitioners should always be prepared for site visits. I certainly have represented limited risk practitioners who have been subject to site visits. And the site visits, frankly, are not so difficult to pass, but with a little bit of diligence and attention. So there's a small number of things that they look for, but things like signage, is there an office, those kinds of things are important there. So I don't want anyone to be who's thinking that they're going to apply for the Medicare program to be overly assured by this. Let's see, one of the things that was really terrific in the proposal under the fee schedule is that applications for the MFTs and MHCs may be submitted just as soon as the final physician fee schedule comes out, which is again estimated to be November 2023, which is great because to be paid for services January 1st, you want to have your enrollment set up before then if you possibly can, so that you don't have to hold your claims and wait a long time to get payment. Next slide, please. In addition, CMS has put quite a bit of inquiry into the proposed fee schedule, where it's asking for information and for ideas from the behavioral health community to help inform not only what's in the physician fee schedule, but sort of broader Medicare payment policies in general. And so if you're interested in doing that, you're going to want to take a deeper dive and read through some of the commentary. But some of the areas where CMS is soliciting input is, access to care in general, particularly behavioral health. There was a note that psychiatrists have a lower participation rate than any other specialty in the Medicare program. CMS is soliciting information about access to behavioral health integration, including the psychiatric collaborative model. They want to know whether interprofessional consultation should be separately reimbursable. So is that something that is really needed and necessary? Needed and necessary under the Medicare program. They are wanting to know whether there are settings in which intensive outpatient services should be reimbursed. What should those settings be? And is there a need for separate coding and payment for interventions furnished in a crisis setting, such as an emergency department for patients with a risk of suicide? So, for example, things that might warrant higher payment are things like safety planning interventions, telephonic post-discharge follow-up contacts, et cetera. And then there are quite a few questions posed by CMS about the use of mobile medical applications for cognitive behavioral therapy. And so they're really asking for a lot of clinical input on that. I've been getting a note about LPC and LMHCs and the terminology that's being used. And I think I am using the California language. And so those are also picked up, different states use different titles. And so the concepts that we've been talking about in this presentation pick up all of those things. The key thing is the word licensure. And I appreciate the note from Dr. Smith on this in my chat. So with that said, that concludes this part of the presentation, and we can now move over to questions.
Thank you, Jeannie, for sharing your time and your vast knowledge of the fee schedule and Medicare with us today. You have provided vital information to move us a few steps closer, of course, to the January 1, 2024 implementation date for MFTs and mental health counselors. And as you said, now we're going to move into the question and answer portion of our program. And during the last few weeks, the coalition had reached out to stakeholders to ask what the common questions were, what you wanted to know about the fee schedule and Medicare for counselors and MFTs. And based on your feedback, we have selected the most common questions and divided them into 3 categories. And the categories that we're going to cover are eligibility, enrollment, and coding, reimbursement, and administrative issues. And our panel is going to answer questions in all of these categories. And I've been watching some of the questions that are coming in as well. I think that they are going to be, a lot of them are going to be covered in the panel part of this discussion. But we're also collecting those questions for future webinars that we will have, and we also will update our frequently asked questions document that we have on our NBCC website to answer some of those questions as well. The panel today consists of Jeannie Vance, the person that just did our lovely presentation. We also have Doug Jacobs, Lindsay Baldwin, and Candace Anderson, all of CMS, and myself, and we're going to rotate answering those questions. The first few questions are going to be answered by CMS, and I'm happy to say, if you can advance to the next slide there. The first question is one that Jeannie was just answering herself, and we might hear more from CMS on this, so I'm going to read the question out and see what they have to say as well. The proposed Medicare Physician Fee Schedule rule uses the following terms for mental health counselors: licensed mental health counselors, licensed clinical professional counselors, and licensed professional counselors. Other designations are used by states include things like licensed professional clinical counselor, which is not included in that list. Despite the rule with the 3 designations highlighted, if a person meets the requirements such as licensed as an MFT or an MHC at the state level to provide mental health services, possesses at least a master's degree, performed the necessary clinical supervised experience, and so on, can I enroll in Medicare despite any slight variations in mental health counselor licensure designations?
Thanks so much for the question. And also just to start out, really thanks for having us here today. It's really exciting seeing so many folks join this webinar. I think a lot of people are really interested and excited. And so happy to be here as an agency talking about the proposed rule. I wanted to start out, I just saw some questions come in the chat about telebehavioral health in particular. I just want to make a quick note on that, and then I'm going to kick it to Lindsay for this question. For telebehavioral health services, they've actually been made permanent. So they don't expire at the end of 2024. Other types of telehealth services have been extended to 2024, but telebehavioral health is permanent. So with that, I just want to kick it to Lindsay Baldwin, who's an expert also in the behavioral health area.
Great, thanks so much, Doug. So going back to the question that was just read off, thanks so much for this question. I think as folks are aware, the proposed rule outlines that MFTs and MHCs must possess a master's or doctor's degree, which qualifies for licensure, or certification as a marriage and family therapist or mental health counselor in the state in which the services are furnished. After obtaining that degree, has performed at least 2 years or as proposed 3,000 hours of postmaster's degree clinical supervised experience, and is licensed or certified in the state in which the services are performed. But we did see lots of questions in the chat that asked specifically about licensed professional counselors, and we did just want to clarify that the statute defines the term mental health counselor to include those who are licensed as clinical professional counselors and professional counselors as well under that umbrella term of mental health counselors. But since we are aware that there are slight variations in the nomenclature by state, we did also seek comment on that in the proposed rule, and I would definitely encourage folks to submit public comments on this, and certainly point out any states where there is an equivalent licensure with slight variation in the terminology used, so that we can be responsive to that in the final rule. And as folks mentioned earlier, comments, the comment period closes on September 11th, and those public comments can be submitted at regulations.gov. I think that addresses that first question.
Yes, thank you very much. And first of all, I want to say, well, thank you all for being here, but that is great news on the telebehavioral health. So thank you for sharing that, Doug. That's just phenomenal. And thank you for answering that question as well, Lindsay, because we do have a lot of people asking about that. So thank you so much. Then can you advance to the next slide, please? There we go. The second question kind of relates to that, and that is, are associates eligible to enroll in the Medicare program and bill for services?
Yeah, I can take this one too. This is a great question. I think that, like with all things here, the terminology really can vary. And so I think we sort of have a question back to you all, which is when you say associates, what specifically is meant by that? What are the requirements? And I think it does just go back to those statutory requirements that I just listed off. Do they have a master's or a doctor's degree? Do they have the 2,000 or the 2 years or 3,000 hours of clinical supervised experience? And are they licensed? So if they don't meet those criteria, then they wouldn't qualify. But to the extent that there are some states that have a licensure that does, I think, again, we would just reiterate to definitely submit those as public comments. Even though we're talking with you now and seeing these questions now, we definitely appreciate getting the questions formally submitted, and so that they're on the record and we can respond to those in the final rule.
Wonderful. Thank you so much for answering that question. And I think this is just a place where sometimes it depends on the state, because every state licenses in a little bit different way. There's a lot of commonality and a lot of consistency across the states, but there are some differences as well in how counselors and MFTs are licensed. So I appreciate you addressing that. And I also appreciate CMS taking comment on that, because that will be really helpful too in the final rule. Okay.
Oh,
so,
and
yeah.
One other thing I'll say on that, sorry, is that to the extent that they don't meet those statutory requirements, but they are authorized in their state to perform the applicable service, there is always still incident to billing that would be applicable. So they could participate in furnishing that care under the supervision of a physician or a non-physician practitioner, and they could do so under general supervision.
Right. And that's a fair point. And that's something that's already in existence, right? So that will
Correct.
continue forward.
Mm-hmm.
Okay, wonderful. Let's move to the next slide. And these are also going to be questions for CMS. The first question is, the MPFS rule includes new language not included in the legislation, that after receiving a degree, an individual who has performed at least 2 years or 3,000 hours post-master's degree clinical supervised experience in mental health counseling will be eligible to participate in Medicare, as well as meeting other requirements. How did CMS arrive at the 3,000 hours number? And is there a definition of clinical supervised experience that CMS can provide now or in the final rule or other guidance? And this is a question we've had actually a lot.
Thank you so much for the question. So we, as was presented before, we proposed that it could be 2 years of clinically supervised experience or 3,000 hours. The reason we chose 3,000 hours, and we talk about this in the rule, is that 3,000 hours is roughly equivalent to 2 years of experience. And so that's how we landed on that exact number. In terms of what we mean by clinically supervised experience, we didn't say specifically in the rule. So this is another area where if folks have thoughts, comments, feedback, questions, really submission of that formal comment will be helpful to us as well as we review them and decide to what to clarify in the final rule as well.
Wonderful. Thank you so much. All right, the next question on that slide is, how will the clinical supervised hours requirement be addressed for practitioners who have been in practice since the 1980s and experience potential documentation challenges?
This is a really good question, and we understand that certainly folks are thinking about that. What we can say for now is just that guidance is forthcoming. Our colleagues in provider enrollment are currently working on drafting manual guidance as well as frequently asked question documents. And they do plan to address this question specifically, but unfortunately, I can't speak to it just yet as they are still finalizing that guidance.
Okay, no problem. I mean, it's great that you all are at least looking at that, because we do, of course, have quite a few people that have been in the profession for a long time, and they're very, they want to know the answers to it. They want to participate. So thank you so much for taking a look at that and being willing to address that.
Yeah, I would just say be on the lookout for that guidance. There is the Medicare Learning Network, for which we use as an outlet for getting information out. But it's forthcoming.
Yes, that's wonderful. And it's also great. I think that you all are encouraging people to make comments too, because this is a way to advocate for yourself. And if you can make those comments, CMS is very willing to listen to those comments and address those issues or problems that are going to be in the implementation of counselors and getting counselors and MFTs integrated. So definitely encourage people to make those comments and submit them to CMS. Okay, let's move on to the next question. If you can, there we go. And this is going to be a question that I'm going to answer. And the question is, and we've talked about it a little bit already, is will addiction counselors have an opportunity to enroll in the Medicare program? And the answer is CMS is proposing to allow addiction counselors who meet all of the applicable requirements, such as a master's degree, and Jeannie mentioned this in her presentation too, to be considered mental health counselors. So they would be eligible to enroll and bill Medicare for MHC services if they have met all of those key requirements that we have covered here. All right. So that actually ends our enrollment question, or our eligibility questions. And now we're going to move into the enrollment questions. And again, we're going to have the first few questions for our CMS colleagues. So if we can go to the next slide. The first question is, how do MHCs and MFTs who meet the applicable eligibility requirements enroll in the traditional Medicare program?
Thanks so much for this question. And I appreciate that you also gave me a little cheat of an answer here too, right on the slide. So as the slide shows, we have online a webpage and hub that folks should really feel free to visit and check out. It has basic information about the provider enrollment process, and it would be good to familiarize yourself with that. Also, as part of this too, we proposed in the proposed rule that providers could, or MFTs, MHCs could start enrolling as soon as the final rule is published. I think it would be good to familiarize yourself now in anticipation of that happening.
Very good. Thank you. The second question on this slide is also for CMS. And the question is, if a practitioner has an NPI number already, is there a requirement to have another for Medicare?
No, you don't need to get another NPI number. We also have certain publications that talk about NPI numbers too, if folks are interested in learning more.
Okay, very good. We've had that question quite a bit too about the NPI number, so thank you for clarifying that. Okay, next slide. And these two questions will also be for CMS. We're putting you all on the spot. We're going to have Jeannie answer some questions. We want to give Jeannie a little break. We're going to put her on the spot in just a little bit. So the first question here is, will the enrollment process begin when the final NPSS is issued? And is there a projected time frame when the final rule will be released?
Yeah, I can just chime in to reiterate what Doug said, which is that we anticipate the PFS final rule to post on or around November 1st.
Okay, very good. Thank you. And the second question here is, how will practitioners be informed by CMS when they can begin to enroll in the Medicare program?
Thank you for that. So there's a number of ways. As Lindsay had mentioned earlier, we have a lot of different ways that we get communications out to the public, Medicare Learning Network. We have different provider listservs. We also have a specific provider communications group and team that work on how to get messages out. And we know we've been in collaboration with the associations who put this call on. So thank you very much. And we'll continue to do so throughout the publication of the final rule.
Okay, very good. Thank you for that. Now we're going to give Jeannie a turn to answer some questions. If we can go to the next slide. Thank you. All right. Welcome back, Jeannie.
Yeah.
The first question for you is, what forms will need to be completed for a practitioner to enroll and be approved in the Medicare program?
Sure. And before I answer that question, I'm just going to say how I learned that the proposed rule was published is because if you go to the CMS main website, there's a press link right on that first opening page, and that has like all the press releases, and that usually things that hit the press release are pretty major, and so there'll be a press release and there'll be a fact sheet and some other things. So if you just go there, like I check it every day, boom, you'll see it right there. So that's probably how I'll get the first word of it. So if you're interested in doing that, you could engage in that same process, but usually there's not a shortage of blasts out there. Okay, going on to question 5, the forms that would need to be completed for a practitioner to enroll in the Medicare program is the 855I form, either electronically or on paper. And then if there is a group that you are a member of or are to join, that group needs to complete the 855B form to get its group enrollment set up. And then you would need to complete something called the 855R form, which just links yourself to the group within the Medicare system.
Okay, thank you so much for that. The next question, also for you, Jeannie, is number 6. After completing the necessary enrollment forms, what is the time frame when the practitioner is notified when they have been accepted or declined to participate in the Medicare program, or if additional information is needed?
Sure. The individual enrollment applications, they're fast. And so this has actually been a great change coming out of the pandemic, is that the MACs really got a lot faster at processing these things. And that is continuing on to this day for practitioners. So if an application is submitted, there's standards that come out that apply to the Medicare administrative contractors that CMS holds them to. And so if the application is submitted within the PAYCO system, the electronic applications, they're required to either notify you that additional information is needed or approve you. I just hope none of you are denied on your applications. That 95% of those have to be processed within 15 days and 100% of them have to be processed within 50 days. So that gives you sort of a window. So if you apply on November 1st, you really should get through that application process by January 1st. If you submit a paper application, the processing times are slower. So this is an advantage of the PAYCO system. So 80% of those need to be processed within 30 days, the paper applications, and 100% within 65 days.
Wonderful. Thank you for those tips too, Jeannie. You know, that's going to really help people set that timeline out if they do want to apply to be a provider. So thank you for that. Next slide, please. And this is going to be a question for me that I will answer. How can practitioners opt out of the Medicare program? Counselors and MFTs will need to complete a form in 2023 to opt out, and they will need to file an affidavit to opt out of Medicare only once, and it will have a permanent effect. The practitioner will no longer need to renew the opt-out process after they have done that once. So MFTs and MHCs have three choices. They can enroll as a Medicare provider, they can opt out, or they can be a non-participating provider. And we have talked a little bit about this in other webinars that we have had, but let me explain a little about what that means. A participating provider would accept Medicare and always take assignment. And Jeannie is going to explain a little bit later what taking assignment is in another question, so I'm not going to go further into that. The second is an opt-out provider, and those providers, they do not accept Medicare at all, and they must sign an agreement to be excluded from the Medicare program. And this means they can charge for services to Medicare clients, but they must follow certain rules to do so by the law. And the third is a non-participating provider, and they accept Medicare but do not agree to take assignment in all cases, so they could accept cases on a case-by-case basis. So the 2024 proposed rule was silent on the opt-out procedures, and NBCC and the Medicare Coalition plan to comment on this omission and give CMS some feedback about opting out. So there could be more information that would be shared in that final 2024 fee schedule rule. That is what we are anticipating. All right, next slide. Thank you. And these questions are going to be for Jeannie. Question 8. If a practitioner opts out of the Medicare program and the client has secondary insurance, how will reimbursement work in that situation?
Sure. So that depends on whether Medicare is a primary or a secondary payer. So if Medicare, and there's information on the CMS website about when Medicare is primary and when Medicare is secondary. So I mean, the CMS website has a lot of information. That and the search bar get you pretty far. So if Medicare is primary, then what would happen is the secondary insurance payment would be reduced by the imputed Medicare payment. So if you've opted out of Medicare, Medicare is not paying for that service. So that would mean whatever secondary insurance payments that you receive would be reduced by the amount that would have been paid for by Medicare if Medicare had paid. If Medicare is secondary, then there wouldn't be any impact on the primary payer.
Thank you. Thank you so much for explaining that, Jeannie. And these, I agree with you. There's so much information that CMS has put out, and it is a lot of detailed information. So some of it you do have to, when you have very specific questions, you do have to kind of sift, but there are answers to the questions on CMS's websites and other guidance documents. So I do appreciate CMS for putting that out there for people as well. The next question is also for Eugenie, and this is, if I work for an FQHC or an RHC or related agencies, will they automatically enroll me in the Medicare program, or will I need to apply through the formal enrollment process?
So in this case, they probably will not enroll you in the Medicare program because they're not, they're billing not based on, the particular services that are provided. And so the way that the claims work, it's not essential that that be done. However, if you're a practitioner who will be ordering and referring services, even within the clinic, then you would need an enrollment for that process. And so you would need to talk to the RHC or FQHC to see whether they will enroll you or whether that's something that you need to do on your own.
Very good, thank you. Next slide. All right, question 10 is going to be one that I'm going to answer. And the question is, will providers need to apply to become providers for both traditional Medicare as well as Medicare Advantage Plan and Medigap policies? The answer is yes. Providers who wish to participate in managed care programs will need to contact the Medicare Advantage Plan to get an enrollment form, fill it out, and return it to the plan. And all plans must offer this option. You can call 1-800-MEDICARE to get more information about that. And for additional information on how to enroll in those Medicare Advantage plans, we have included some links on this slide for you. All right, next slide, please. And this is going to be a question for Jeannie. If I am part of a current health insurance provider panel or network, will I automatically be eligible to treat Medicare beneficiaries?
Not necessarily. So you're going to have to meet those requirements that we talked about. So the, supervised clinical experience, licensure, all of the master's degree, doctoral degree, all of that. And the health networks within, a health plan organization are specific to a given plan. So, it might give you an in to try to get on the Medicare Advantage contract, but usually, there are particular provisions that have to be pulled into your contract, et cetera, that would not be in place for a non-Medicare Advantage provider contract. So, contact your health plan and see if they'll, expand your existing contract or, give you a new one for your Medicare Advantage plan.
Okay, thank you. Next slide, please. We are now going to move into the coding, reimbursement, and administrative issues. So we have a few questions. They only have a few minutes left, so we're going to get through as many of these questions as we can. And the first one I'm going to answer, and the question is, what Medicare CPT codes for mental health services will MFTs and MHCs be able to bill for starting in January? The Medicare Physician Fee Schedule does not provide specific details on common codes that Medicare will reimburse mental health counselors and MFTs. However, there is a list of the most common CPT codes for mental health services that Medicare reimburses providers, which can be found in the Medicare Mental Health Booklet. And that is on pages 22 through 25, and we have provided you the link on this slide. The next question, or the next slide, there's two questions there, are going to be for CMS. And the first one is, are there any limitations in the legislation and proposed rules that will limit where MFTs and MHCs can bill for services when treating a Medicare beneficiary?
With this one, maybe I'll kick it to Lindsay. Do you have thoughts on this one?
No, I'm not aware of any limitations. I think there are some separate, there was separate rulemaking on certain settings, I believe related to skilled nursing facilities and others, but not aware of limitations other than that.
Okay, thank you. The next question is, what is the payment formula for services that mental health counselors provide to beneficiaries? And Jeannie, I believe you covered that in your slide. So that, I think we will, and we have included a link here as well for the physician fee schedule lookup. So I think we might skip that one. And we are running out of time. We have maybe 1 minute left here. So I'm just looking through to see. I do want to cover this question on slide. Can you go to slide 45, please? Thank you. And what does, Jeannie, this is for you. What does provider assignment mean? I want to make sure that we cover that, since I said you would cover that later in the questions.
Sure. What it means is if a practitioner takes assignment, it means that that practitioner bills the Medicare program direct and receives payment from it directly. There's an alternative to that, and you can still get Medicare payment as a non-participating provider, which means you would enroll in Medicare, but you would not sign the CMS 460 form, which is the participating provider agreement, and then you would be enrolled as a non-participating provider. There you would bill the patient, and then the patient could submit a claim to Medicare to get reimbursed. There you would be subject to a cap. It's a little bit higher than the Medicare rate, so it's 115% of the Medicare approved amount, but so you would still be subject to that cap on the fees. So that's what it means, provider assignment. Is you take what happens is technically the payment goes to the beneficiary, and if you take assignment from the beneficiary to receive your payment directly from the Medicare program.
Wonderful. Thank you for explaining that. Unfortunately, we are out of time. We had a few more questions that we were hoping to cover, but like I said, we will try to put those answers to those questions on our frequently asked questions document that will be on our NBCC website. The Medicare Mental Health Workforce Coalition and NBCC would like to thank our speakers for today, Dr. Beverly Smith for giving greetings, Jeannie Vance, Doug Jacobs, Lindsay Baldwin, and Candace Anderson for sharing your knowledge, for being willing to answer our questions and to listen to the questions and take feedback back to CMS as well. And thank you to all the participants that attended the meeting today and for submitting questions. We had some really good ones, and I think we covered quite a bit of ground. The link to the session evaluation is posted in the chat, and we will also email it to you following the meeting. To receive continuing education credit, you must complete the evaluation by August 31st at 5 p.m. Eastern Daylight Time. The certificates will be emailed by September 6th. We will only be providing credit for the live attendance of this webinar. We hope that you found this session informative, and we look forward to seeing you in future webinars. And we thank you, and thanks again to our speakers, and have a wonderful rest of your day.